Just a second. Actually, the aim of today's discussion is to have some insight about how to evaluate a patient regarding cardiovascular system, because every there is some noise in background. I don't know. Just a second. Let me try to. Yes. Actually, I just want to say that whenever we are evaluating a patient with regard to cardiovascular system, we are just trying to have some symptomatology which may reflect any borderline or any cardiovascular any involvement of the cardiovascular system. So if anyone wants to volunteer, what are the usually the cardiovascular systems which may be like indication that this patient might have some problem related to cardiovascular system? What are the usual symptoms? Anyone wants to participate? Okay. So actually, it may be like symptoms may be related to shortness of breath. Okay. For example, if we just focus on this, so shortness of breath is maybe related to anything related to cardiovascular system or respiratory system. Just a second. I think we will just hold for a while. And the person to whom we give some task to prepare a presentation, he's joining soon. So we will just wait for a few more minutes. Yes, Hasib, are you ready?
Assalamu alaikum. Yes, I'm ready.
Will you share your screen or what?
Welcome, Hasib. Share your screen and start your presentation, and then we will have a discussion.
I'm sharing my screen and going to start. Okay, Bismillahirrahmanirrahim. Our today's topic is preoperative cardiac evaluation, and in general, if we talk about preoperative evaluation of any case, the following parts, we have the following goals, like the primary goals of first of all, the following are the primary goals of preoperative evaluation and preparation have been identified. First of all, the documentation of the conditions for which surgery is needed, then the assessment of patient's overall health status, undercovering of hidden conditions that could cause problems both during and after surgery. Then perioperative risk determination, optimization of patient's medical condition in order to reduce the patient's surgical and anesthetic perioperative morbidity and mortality. Uh, then we have education of the patient about surgery, anesthesia, and intraoperative care, reduction of cost, shortening of hospital stay. These are the major goals. Then in general, pre-operative patient education, counseling, and consent taking is most important. Then pre-operative pain management, psychological symptoms, fear, anxiety, depression, we have to deal with these. Then important thing is history, detailed history of every system and specific to the diagnosis. On examination, general physical examination, airway assessment, and specific system, especially cardiorespiratory system, because these are the most important systems in the aesthetic concerns. Then, for example, for investigations, baseline investigations, and including X-ray, ECG, echo, and other available according to specific systems. vital monitoring, risk assessment, medication considerations, referrals, optimization, surgery, surgery and the further surgical discussion and planning, risk stratification, urgency scaling, bleeding risk, incision site, surgical technique, medical intervention, thrombosis, post-operative nausea, vomiting, aspiration, angiolysis, ulcer prophylaxis, multimodal analgesia, pulmonary complications, cardiac risk, renal risk, consent and counseling, continuation and stoppage of medicines, angiolysis, ulcer prophylaxis, multimodal analgesia, induction plan, airway plan, fluid plan, IV or invasive lines, monitoring, maintenance, muscle relaxants, certain blocks, adjuncts, and blood products, and then at the end extubation plan. For the first of all, when we discuss the risk assessment, in this risk assessment, patient's assessment according to ASA, anesthesia, American Society of Anesthesia scoring system, med scoring, cardiac risk assessment. In further, we will discuss about this in details, and we will discuss today ASA scoring, meds and cardiac risk assessment today in detail, because our topic is related to cardiac risk assessment, pre-operative evaluation. First of all, if we discuss the ASA status, because this is common in all operations and especially in cardiac and other systemic diseases. ASA1. ASA1 has a normal healthy patient. Healthy means healthy, non-smoking or no or minimal alcohol use. Healthy according to BMI also. No acute or chronic disease. These type of patients came under ASA1. Then ASA2, these are about the systemic diseases, not the surgical diseases. So we would have to keep in mind that these are based on the systemic diseases. A patient with mild systemic disease includes functional limitations, current smoker, social, alcohol drinker, pregnancy. Normal pregnancy includes in ASA2. Obesity greater than BMI 40 and less than BMI, greater than BMI 30 and less than BMI 40. Well-controlled diabetes mellitus and hypertension. If these conditions are present, like diabetes and hypertension, but are well controlled, then came under the heading of ASA2. Mild lung disease, asymptomatic congenital cardiac diseases, well-controlled dysarrhythmias, asthma without any exacerbation, well-controlled epilepsy. In short, all the well-controlled systemic diseases fall under the heading of ASA. Further include OSA, oncological state in remission, autism in mild limitations, normal pregnancy, well-controlled gestational diabetes, hypertension, and this. The next is ASA3 classification. In ASA3, a patient with severe systemic disease that is uncontrolled, like poorly controlled diabetes mellitus, hypertension, COPD, morbid obesity, active hepatitis, alcohol dependence or abuse, implanted pacemaker, moderate reduction of ejection fraction like 40% or below, end-stage renal disease, undergoing regularly scheduled dialysis on like maintenance dialysis, 3 months or greater than 3 months history of MI, CVA, TIA, or coronary artery disease, stents, uncontrolled stable congenital cardiac abnormality, asthma with exacerbation, poorly controlled epilepsy, insulin-dependent diabetes mellitus, morbid obesity, malnutrition, severe OSA, oncological state, renal failure, muscular dystrophy, cystic fibrosis, and likewise. And the important is preeclampsia with severe features, gestational diabetes mellitus with complications or high insulin requirement, a thrombophilic disease requiring anticoagulation. These all fall under the heading of ASA 3. Then ASA 4, a patient with severe systemic disease that is constant threat to life. Recent means less than 3 months history of myocardial infarction. CVA, TIA, coronary artery disease, ongoing cardiac event or ischemia, severe valvular dysfunction, severe dysfunction of ejection fraction, shock, sepsis, DIC, ARDS, and stage renal disease not undergoing regular scheduled dialysis, symptomatic congenital cardiac abnormality, congestive heart failure, active sequel of prematurity, acute hypoxic ischemic encephalopathy, shock, sepsis, and ventilator dependence, and endocrinopathy, severe trauma, severe respiratory distress, advanced oncological state, preeclampsia with severe features of developing HELP syndrome, pericardium cardiomyopathy with ejection fraction less than 40%, decompensated heart disease, and so on. Then came the ASA 5, a moribund patient who is not expected to survive without the operation. These include ruptured abdominal or thoracic aneurysm, massive trauma, intracranial bleed with massive effect, ischemic bowel in the face of significant cardiac pathology, and multiple organ system dysfunction. Massive trauma, intracranial hemorrhage with mass effect, patient requiring ECMO, respiratory failure or arrest, malignant hypertension, decompensated congestive heart failure, hepatic encephalopathy. These all came under the ASA 5. Then we discuss about the
Just a second, Hasib, I will
cardiac
just interrupt you for a second, because the aim for today, because this is a presentation which we prepare actually for generalized pre-operative evaluation. Okay, so now if you can focus primarily on cardiac. Okay.
Yes. Couldn't hear
Like
you
as
properly. Yes.
like as anesthetist, when we see a cardiac patient, what are the usual symptoms would you like to see, or what are the usual symptoms which you ask the patient, or which are the usual symptom which warrant you towards any cardiovascular problem?
Yes. Coming towards these signs and symptoms related to cardiac diseases. First of all, patient having signs and symptoms of, if we discuss about heart failure, then signs and symptoms of heart failure include tachypnea, blood tinged sputum. These are the of pulmonary congestion and overload symptoms. Cough, pink frothy sputum, fine basal crackles, wheeze, blood tinged sputum, tachypnea. Then came the elevated pulmonary capillary wedge pressure or raised CVP or JVP, paroxysmal nocturnal dyspnea because having pulmonary edema, restlessness, confusion due to hypoxia, orthopnea, tachycardia, exertional dyspnea, fatigue, cyanosis. These are all the signs and symptoms of left-sided heart failure. Then if we discuss about the right-sided heart failure or pulmonary, these includes fatigue, increased peripheral vascular pressure, ascites, enlarged liver and spleen, hepatosplenomegaly, jugular venous distension, anorexia, weight gain, dependent edema. Then came about the clinical predictors in mind.
Just a second, Hasib. What can we differentiate on signs and symptoms between cardiovascular system and respiratory system? Like which symptoms will or which signs will be predominant towards the respiratory system and which will be towards cardiovascular system?
If
Or
we
we need to have some investigations for that.
yes, to distinguish between cardiac and respiratory symptoms, first of all, we will have the detailed history.
Like
The first predictor
if you just focus only on this symptom of dyspnea. Okay, can you
Dyspnea.
differentiate between if it is because of respiratory system or it is because of cardiovascular system? This is just a critical thinking, just okay. So if you want to differentiate, can you differentiate?
Oops. Yes. If Yes, we have to differentiate on the basis of history. First of all, like a patient came in emergency and he is having shortness of breath. We have to exclude the cause of shortness of breath. Is it due to respiratory primary cause or secondary to the cardiac symptom? So we will ask him about that history. About the ischemic heart disease, some are the risk factors which increases the risk of MI. These includes hypertension, diabetes mellitus, past family history of ischemic heart disease or non-ischemic heart disease, smoking, hypercholesterolemia. If these are positive, then we have to think keenly about ischemic heart disease. Next, we will ask about shortness, chest pain. If the patient is having typical chest pain, then more favors towards the ischemic heart disease. If otherwise, less chances. Most often, there is atypical chest pain. If we discuss about the character of chest pain, in ischemia, it is having central exertional chest pain in the form of heaviness. Okay. It can also be in a pain epigastrium, or even back pain can also be due to ischemia. And
So can
the
we differentiate between pleuritic chest pain and typical cardiac chest pain?
pleuritic chest pain increases with the respiration and leaning forward. It relieves with leaning forward and increases with respiration. And in cardiac chest pain, it is it relieves with rest. If it is angina, it relieves with rest. If it's not angina, it doesn't relieve with rest. It's in the
Actually,
form of heaviness overall.
I will just add few words in this aspect.
Hanji.
That if, for example, if you have a dyspnea, you will be looking
Han-
at the associated symptoms. Okay, if it is
Yes.
dyspnea related to, for example, if you say that it is because of bronchospasm or there is the patient, it is because of predominant COPD based. Okay, so you will be having the auscultation or inspection. You will be finding some other fine symptoms which will be heading towards COPD. Okay, or and you will be using some bronchodilators, that patient will be responding to bronchodilators. On the other side, if the dyspnea is associated with, like just like he was telling about chest pain, so it may be chest pain and dyspnea may be combined, and that will be toward heading towards ischemic pain. Okay, and that will be responding to nitrates. Okay, so that's how you
Yes.
can, because as a emergency physician, as a ICU doctor, or if you are evaluating a patient intraoperatively, or if you are evaluating a patient who is going for surgery, our approach is a little bit different than the typical physicians. We have to pick out the business end. Okay, so that's what I just wanted to highlight a little bit, because this is the way you can differentiate by the basis of, and because of course you cannot decide only on the basis of history and examination. Some of the points, like you told, that if the patient has history of diabetes, hypertension, and now it is presenting with this condition, so you are heading towards that maybe it is because of atherosclerosis, which is prevalent in these patients. Okay, or but you need to have ECG or chest X-ray to for further evaluation. Okay, and you
Yes.
are
Yes.
managing step by step. So this is just a sort of critical thinking which I just wanted to you to, because
Yes.
this is the same thing which the examiner asks you in the long case. And if you have a
Yes.
practice like that in every patient, you will never fail in long case, I guarantee you, because this will become your second nature. Okay, as the other symptoms you have
نهار انستيزيا يوزوم ده غدا عارف.
okay. Okay, Asif, now you can
Yes.
continue, please.
Yes. Furthermore, we can differentiate about on auscultation, like if a patient is having exacerbation of asthma or COPD, then these is most predominant finding we can find The chest would be barrel shaped. Patient is taking breaths with exertional dyspnea, with using accessory respiratory muscles. But in case of cardiac cause, the patient would be in left-sided heart failure, pulmonary edema. We will find having basal crackles or fine basal caps or other signs of pulmonary edema. These and
Sir,
if
I have a
prolonged
question here,
edema, then
please.
yes.
So my question is, for example, if you are physically examining a patient or for any surgery, you mean you are expecting any cardiovascular problem, okay?
Yes.
And like in our cases, it's very difficult for us to find any murmur. And
Yes.
how can we basically check for, we can go for any murmur, as you know, there is chances of aortic stenosis or any other conditions. So how we can
I understood. I understand your question. I will give you a different vision. Actually, as an anesthetist, you are dealing. You are not the physician to treat or diagnose murmur. Okay, for you in 2022, vision will
sir,
be whether there is any associated symptom or any associated finding which you are getting. And as a cardiac anesthetist, you Amir bhai will also appreciate that you will be doing echo. You will be having a focused echo to find any sign of failure. You will find the answer in yes or no. Contractility is good or contractility is bad. Am I right? So I think we are
Yes.
beyond the stage of finding murmurs with the stethoscopes. This is maybe my answer is a little blunt, but actually, when we are focused on the patient management, we are actually not the primary physician to diagnose. Unfortunately, still in our exam, they are interested in diagnosing the murmurs. But actually, your answer is yes. We are the concept of focused echo is finding towards any decompensation, yes or no. Or you can differentiate between mild or in this word. Okay, you are not doing echo like a cardiologist. You because for that you will be deciding intraoperatively, are you giving some inotrope, or are you giving some fluid, or are you giving some vasopressor. Okay, Harun. So the murmur, yes,
Yes.
it sometimes becomes very difficult. Okay, sometimes it becomes very difficult for anesthetist to pick a murmur. But you will be because you are on the business end, you will be label it as combining the other signs and symptoms. You will be labeling it as a compensated or a decompensated. Okay, and you will stratify the patient in the form of New York Heart Association classification, or this one the Canadian class of angina classification, whether it is falling in 1 or 2 or 3 or 4. If it is in falling in 3 or 4, it is towards decompensated phase. Okay, it is, you will label it as unstable or active cardiac condition or major cardiac predictor. So this is what is the aim of evaluating cardiovascular system for anesthetist. You understand? Unfortunately, we are in a hybrid time. Maybe after few years, the our aims and objective will become even totally different. Okay, this you will label it as ASA 3 or 4. You will be labeling it as what immediate management you need to do, and then you will correlate, as Hasib mentioned in it, that you will be stratifying the surgical urgency, and then you will be deciding whether this patient is compensated or decompensated. If it is not emergency, you will optimize the patient. That is the theme of cardiac evaluation. That is the theme of what European Society of Cardiology or American Heart Association make a chart for a cardiac patient for non-cardiac surgery. Okay, I hope you understand the answer.
right, sir.
Yes, Harun,
The role
as
of
well.
anesthetist is not to diagnose diseases. We just have to know about the diseases, and if we need any evaluation, we have to refer the patient to cardiologist or any specific consultant to give his consultant opinion. But as far as murmurs are discussed, if these are above severe or like mitral stenosis, severe mitral stenosis or moderate, plus 3 plus 4, we can distinguish them on auscultation. Maybe we could not distinguish about systolic, early systolic, pan-systolic, but we can distinguish that there is an additional sound present, and we should have to evaluate that sound. Moreover, there would be some sign and symptoms the patient would be having. If it is having dealing with severe stenosis or regurgitation, there must be some associated symptoms. If these symptoms, sign and symptoms are present, then we have to evaluate these sign and symptoms and refer the patient for further evaluation to cardiologist and so on. I think you got the answer.
Okay, so
Ji.
that is the message. All of you are on board with us, because you will find these things written everywhere, and if the problem is only the interpretation. What do you mean by minor risk factor? What do you mean by intermediate risk factor? What do you mean by active cardiac condition? Actually, the more important thing is how to interpret them. What to do next? If you have found a murmur, what to do next? This is more important. Okay. So what on what thing you will be proceeding and what thing you will not be proceeding, that will be related to the discussion related to the blood pressure. Okay, so like if you are measuring the blood pressure or heart rate, what is the interpretation? If you find a patient tachycardic, what what will you be doing? That is what you will be doing. Yes, Harun, you can answer this. If you find in pre-operative evaluation, you find a patient with tachycardia, what will you do?
Sir, we
Rule out
will
the cause.
so we will rule out the basically why it's causing tachycardia. Is there any something? Basically, there are many causes. We will basically rule out the cause.
You will be correlating. You will be correlating with the other history finding. And then if you, for example, the same tachycardic patient, maybe only because of anxiety, the white collar anxiety. Okay.
Yes.
Or if you find some
Operational
other,
OT.
yes, you may find some paroxysmal finding. For example, you have tachycardia, now you have headache, and a young patient. Now your mind is going towards pheochromocytoma. You have a young lady with some menstrual problem history, and she's also saying that she's unable to sleep. Now you are heading towards hyperthyroidism. Okay, so like your job is to, if you are, because you will be finding either diagnosed patient or undiagnosed patient in
So
emergency.
basically, how we can just exactly go to the pheochromocytoma in a young patient with headache or tachycardia? How
Like if
just we can exactly
no,
pinpoint
no, we cannot
pheochromocytoma?
pinpoint. We cannot pinpoint, Harun. I'm just telling you that you have to rule out. You have to rule out if you have a finding of severe headache, blood pressure, perspiration, tachycardia. You have to rule out pheochromocytoma, because it may be
Very lethal.
yes, it may be a lethal, because if you will find this, this is what you are supposed to do. Okay, so
Okay,
that
sir.
is more
For
important.
example, okay. For example, patient with headache and as you said, tachycardia. So either it's our duty to go for the CT scan, brain.
No, actually, I'm telling you that your aim is to refer. You are not the primary
Okay,
physician. That's what Hasib told
right.
us, that we are there to pinpoint us that, for example, there is tachycardia, blood pressure high, and this symptoms like which are need to be checked. Okay, so that's what I'm just giving you a hint. Okay, because unfortunately we are not the primary physician. Again, I'm saying the same thing. Okay,
Sir.
like for okay, so we just up till now we have discussed some symptomatology. Like if you just recall, cough,
Shortness of breath, cough,
shortness of breath, and these are the main and another symptom which we need to say is ischemic. Okay, so ischemic symptoms we can find, Hasib, which ischemic symptoms we can find?
Ischemic symptoms would be chest pain
Very good.
associated with nausea or vomiting. These
Okay.
chest pain could be in also it can be in abdomen or in back, and the
No, no.
pain
More
could be
important.
radiated in. Yes.
More, that is the character. This is one is cardiac ischemic pain. Okay.
Yes.
Other ischemic pain you can encounter in a cardiovascular patient is,
ST elevation.
please, Dr. Humera, understand the question before answering. The answer is the ischemic pain may be in the limb ischemic pain. Okay.
Limb acute abdominal ischemic pain, bowel
And
ischemia.
And more bowel ischemia will be, yes, it will be there, but actually another important thing is in the form of any TIA. Because if there is
mesenteric
ischemia,
ischemia.
yes, mesenteric ischemia will be, yes, it can be also be there, but that will be in a different way. But mainly, if you are having a patient with ischemic heart disease, the others associated will be more likely
Yes.
is either peripheral vascular disease or cerebral vascular disease. Other ischemic pain can be there, but they are less important as compared to what I told you. Cerebral vascular disease and limb ischemic pain because of atherosclerosis. Okay.
Yes.
Okay.
Jaw pain. Pain in the jaw, angle of mouth.
These are the cardiac associated pain. I will discuss the characters of. I have discussed the character of the pain, like this is in form of heaviness, central chest pain, and radiating. Then we should have to know the radiations of the pain. These cardiac pain can be radiated to the neck, to the jaw, to the left arm, typically to the left arm, but can also be in the right arm. So we could not to conclude that the pain is in the right arm, so we are fine with excluding the cardiac pain. We have to keep in mind all the risk factors of the ischemic pain and other associated factors. Like associated symptoms of chest pain includes vomiting. So if there is a simple patient came, like sometimes in diabetics, there will be silent MI, or the patient just came with pain, abdomen and vomiting, or just vomiting and shortness of breath. So we should have to keep in mind that is the patient diabetic or standing diabetes mellitus. Like for example, if the patient is having diabetes mellitus for more than 10 years, then the pain he would experience less cardiac pain or any pain. So we should keep in mind all the known causes the patient has, and then evaluate all the signs and symptoms he is presenting with.
Next step will be ECG. Okay.
Then
Next step will
ECG.
be you will be
ECG.
correlating it with ECG, echo,
On
and cardiac enzymes. Okay. You will be
yes,
correlating
on
this.
ECG. Some of the findings of the ECG are typical. We should not that after these findings we could not wait for any other support of symptoms or this. This is the ST elevation MI. If we have ST segments elevation in ECG, no need to check other labs like cardiac enzymes or this and that. That ECG, if patient is having ST elevation, then sure shot he is having acute ischemia. Then other non-ST segment elevation MI includes T wave inversions. These are the non-specific changes. ST segment elevation or N-STEMI or non-ST segment elevation, always we have to conclude on 2 or 3 things. First of all is the typical history. If the patient is presenting with the typical sign and symptoms of cardiac pain, then it favors the ischemic pain. Then second, and cardiac enzymes. If the patient is having positive cardiac enzymes after 4 to 6 hours, then it favors that patient is having NSTEMI. Third, on ECG patient would have like T wave inversions or ST segment depressions. These are the most 2 common findings we could have on ECG. If we find them on ECG, we have to
So should we
the
go?
cardiac
Should we go for TROPI in this case?
Yes, TROPI. Actually,
we
you know
have
what?
to
You
We
actually,
have to correlate clinically, like in females, T wave inversion is normally present in lead 1 to 3, V1, V2, V3 normally present. If a young patient without having any chest symptoms, having normal otherwise ECG, having just 3 T wave inversions, we could simply rule out on history that patient is not having ischemic changes on ECG. These are the normal changes. But if the patient is complaining of chest pain or giving a recent history of any typical symptoms or even atypical symptoms of ischemia, and ECG is also showing the T wave inversions, then we have to rule out the ischemic issues. We have to refer it to cardiologist so that he can perform an echo, do some cardiac enzymes or any stress test further to exclude the active ischemia. Because nowadays ischemia is all cardiac ischemia is also common in young age, so we could not even rule out on age that patient is young so he cannot having ischemia, or the patient is female, she could not have ischemia in early age. Because familial history is also an important role in having ischemia. Then on ECG further.
Sir, I have a question, please.
Yes.
Sir, I have a question. Sir, yeah, in the first paragraph, you have written minor predictors include advanced age, any abnormality in the ECG, any rhythm other than sinus, and reduced FRC. How can we assess FRC? Sorry.
Yes, yes, carry on.
How can we assess FRC as clinically? Like, should we go for any plethysmography?
No, we don't.
How we can assess? How can we assess that patient have reduced FRC?
that's why you should not read an each and every line of things written. Some things may be wrong. Okay.
So that's why I'm
This
asking.
is reduced METs, I think. It is not the it should not be FRC. I think it should be reduced functional class, functional capacity. Okay, it should not be FRC.
Then what it should be reduced METs?
Yes.
Reduced METs or functional capacity of the patient.
Just you now remove FRC and take it as METs. Does it make sense or no?
METs stands for, sir, what's METs?
Metabolic
we will
equivalent.
discuss this on.
Okay,
Yes.
okay. Okay, right, sir.
Okay, Hasib, go forward. We are running short of time.
Then past medical history of cerebrovascular accidents and uncontrolled systemic hypertension. These are the clinical predictors. Intermediate predictors include prior myocardial infarction, mild angina pectoris, diabetes mellitus, compensated cardiac failure, renal impairment, and major predictors include unstable coronary syndrome like ACS, decompensated heart failure, any potentially malignant cardiac arrhythmias like VT, SVT with having more than 180 rate, or fast AFib. These are the malignant cardiac arrhythmias. And severe valvular diseases like aortic stenosis, mitral stenosis, and so on. Then
Sorry,
we will
I will
also
just in some books, in some guidelines, it is written minor predictors are not written. Okay.
yes.
Intermediate predictors, they write it as clinical risk factors. Okay. And all these are actually Lee revised cardiac risk index. They all include these 5 things. Actually, we should be starting from the active cardiac condition. If you see in any patient, unstable coronary syndrome, like can you go down a little bit in this presentation, Hasib? I will just show them. If you want to label, go down a little more. Yes, stop here. This is New York. Go a little up. Yes. Okay, so New York Heart Association classification and Canadian class, actually they are the same. Okay, if that's what I told you, class 1 and class 2 with ordinary symptom or mild symptoms or on severe activity. Okay, similar, if there is chest pain, it is Canadian class. The name are different, but actually one is labeling for heart failure and one is labeling for angina. Okay, so we label it. If it is 1 and 2, go up. If go up, Hasib. If it is 1 and 2, it is clinical risk factors. Okay, it is intermediate predictors. It is called as compensated heart failure or mild angina. Okay, and if it is in 3 and 4, it is unstable coronary syndrome or decompensated heart failure. You understand? Like if you saw a patient, if you saw a patient and in which the patient has raised JVP and patient is dyspneic on rest while talking, he is unable to complete one sentence, or he is not so he is in decompensated heart failure. Or for example, if he is having chest pain, you will say that it is an unstable coronary syndrome. So that is that you will not do any elective surgery in such patient. Otherwise, you have to proceed. You will proceed in such patients only in one condition: if surgery is emergency. Now you cannot delay it. You have to proceed with it. Okay. In this scenario, you will be just optimizing whatever you can do immediately and avoiding further decompensation. Am I right? You will be avoiding
Yes.
further decompensation. You will be doing the arterial line. You will be using etomidate for induction. You will be giving judicious fluid. You are monitoring the urine output. You may get ready with CVP and inotrope and vasodilators ready. Okay, so these are the things which you will be doing while you are doing such patients with with the active cardiac condition. So when you are evaluating a patient, the story does not finish at this point. You have to think what you have to do if you are dealing this patient in emergency. Of course, you are referring the
We have
patient
to
if
perform the surgery.
yes, if in this condition, this is the what you are anticipating. Okay, and that's what we do. We prepare all the emergency medications, prepare vasodilators, inotropes, vasopressors.
Inostrobes.
Okay, and you are trying to have opioid based analgesia. You are avoiding further stress. You are avoiding further change in myocardial oxygen demand supply ratio. So that is the end result of these findings which you are taking. Okay, if you have a patient with insulin dependent diabetes mellitus, and for example the same patient has renal impairment, now it means there are two risk factors. So if it is also you are finding some angina symptoms, then now this patient has three risk factors. So now in that scenario, first of all, you will be digging it further. You will be doing some echo. You will be doing thallium scan, or you will be doing cardiopulmonary exercise testing. Harun, you were asking CPAT. CPAT is cardiopulmonary exercise testing. Okay, in which you
Sir,
check the cardiopulmonary status. And METs, this is what is MET. Hasib, you can explain METs.
This before explaining METs, the other thing is surgical specific risk. If because we also categorize surgeries in three categories like high risk surgeries. High risk surgeries include greater than 5% of the cardiac risk in these all major emergency major operations in especially in elders, prolonged procedures involving large fluid shifts and blood losses, major vascular and peripheral vascular surgeries. These all are included in high risk surgery. Then came the intermediate risk in which 1 to 5% of the cardiac risk is present, intraperitoneal or intrathoracic surgeries, orthopedic and prostatic surgeries, carotid endarterectomy, head and neck surgeries. These came under the heading of intermediate risk. And then came the low risk procedures, include just superficial like breast surgery, cataract surgery, endoscopic procedures in which less depth of anesthesia and monitoring is required. Then the most important, the thing we were discussing, the METs. What is METs? It is the clinical assessment of patient identifying as being at risk. The one MET represents the oxygen consumption of resting adult 70 kg, 40 years, and this oxygen consumption would be 3.5 milliliters per kg per minute. This is equal to 1 MET. And if we discuss detail in scaling of the METs, then we can from 1 to 10, these are the total scoring of the METs. We further subdivided into 1 to 4 METs, 4 to 10, and greater than 10. 1 to 4 includes eating, dressing, dishwashing, and walking around the house. Like if a patient is sitting and just could only eat and dress up, it could be the METs of 1 and 2. Or if the patient can dishwash or walk around the house, then the METs would be 3 to 4. Then the further climbing a flight of stairs, walking on level ground at 6 kilometers per hour, it could be having 4 to 5, 6 METs. Running briefly, 7 to 8 METs. Playing golf, 8 to 9, or even 10 METs. And greater than 10
Do you
includes
know what is
sternal.
implication of this clinical, like what we are getting from it?
Yes,
What
we
is
will
the message?
discuss further in detailed scenario that at what METs we should have to proceed further or not. There is an algorithm for that. We will discuss.
It should be for our
further.
surgery. It should be more than 4 METs.
Yes.
Okay. And
More than
actually,
4.
in a simple way, to
Elective.
a newcomer, I will explain it that lungs are getting the oxygen, okay, and transferring it to the blood. So the evaluation of METs is to see whether the pumping of the heart and utilization is occurring or no. That is what is METs. If the lungs is delivering the oxygen in the blood, but it is not being utilized, then it doesn't make any utility. So that is, if the patient is dyspneic, he is not able to utilize it. Either there is problem in the pumping, or it is in peripheral areas, it's not being utilized. So that is telling you a message that that the patient is unable to utilize the oxygen, which if it is there in the body. Okay.
So how we can measure METs?
We will discuss,
just
because
asking these
actually
questions.
you are absolutely right. Now, for the first time, you understand that pre-operative evaluation is so much important. You have to anticipate, and you have to uh, plan everything on the basis of it. Okay. Because maybe we'll not be able to finish it today. We will
Excuse me, sir.
continue.
How does MET will change the hello?
Outcome.
Sir,
If
how do
greater than 4 METs, if
how
the
do
patient
MET
is
will change the plan of the anesthesia? I
Yes.
want to know.
yes.
Yes.
If
Hasib, you try to answer. If I will help you.
yes, if we ask the questions and patient is having METs from 1 to 4, then we could not perform an elective surgery. We should have to evaluate the patient because he is having some type of distress. We should have to evaluate for the 1 to 4 METs. We could not perform an elective surgery in patient having 1 to 4 METs. But if the patient is falling under the category of 4 to 10, then it means the patient
Hasib,
having
Hasib,
much.
I am putting a question to you. You have a patient with
Yes.
osteoarthritis. Patient cannot
Yes.
walk. How will you evaluate 1 to
Yes.
4 METs? For that, you need to do the stress testing. Okay.
Yes.
If either patient is getting symptomatic by itself, or patient you cannot evaluate because there is some physical limitation. Okay. In that case, you are doing the stress testing. You are doing either stress thallium, or you are doing stress echo to see how much
What
stress patients.
METs?
And the question which Asif you asked is that, for example, if you have a patient who is unable to utilize the oxygen, or unable to have the oxygen, or the reason may be cardiovascular or respiratory. Okay. If there is some cardiovascular problem, patient is not able to pump the heart is not able to pump it, then patient will be dyspneic. If there is some respiratory problem, even then METs will be decreased. That's what we see in respiratory disease patients. Okay. So the interpretation, actually we are not following the exact numbers. Okay, the cardiopulmonary exercise testing is a test. I'm not sure it is occurring anywhere in Pakistan. I think it will be there in MIC, I suppose. Hasib can tell us that cardiopulmonary exercise testing occurring in MIC or not. But anyways, in that way, there is a mechanism in which not only they are doing the exercise tolerance test via ECG, and they are giving a mouthpiece, and they are having the respiratory parameters at the same time. So they are checking the anaerobic threshold and maximum oxygen consumption. That is maximum how much patient is take. So there is a mechanism with which they are calculating it. Okay. So anaerobic threshold is that at which patient is usually as much as oxygen is being utilized, as much CO2 is being produced. If, for example, there is extra CO2 which is produced disproportionately than oxygen being used, so that it means there is some anaerobic source of production of CO2. Okay, so that's what we say, that patient is having that limit, that the limit at which anaerobic threshold comes, that we say that there is some anaerobic source which is there. Okay, which is that after that oxygen is not being utilized. So that actually that is a separate topic. We will try to do the cardiac monitoring and cardiac investigation in detail, because I was thinking to finish it in one session, but I think we will not be able to finish it today. So we will finish as much as we were able to do in next 5 to 10 minutes. Okay. Yes, Hasib, you are getting the concept. So that
Yes.
is, this is what we do in Lee revised cardiac risk index as well. And previously we used to do this Goldman cardiac risk index. It was it was done by, just a second, this is Goldman. You may not, you may find it in still in MCQs, you will be finding it. Okay, they used to do it, but the purpose of any perioperative cardiac risk stratification is to see where you fall. And if there is more risk, there is more chances of cardiac mortality and morbidity. And in those patients, you are either optimizing the patient, like you can advise some anti-anginal, you can advise some like heart failure, diuretics, beta blocker, whatever according to the situation what is being required. Like this, the word will be optimization. And then the patients in which you have to proceed, you will be doing the risk stratification, as I told you. Okay, so up till now we have discussed about history, about which are the main cardiovascular symptoms which you see. Another symptom which we because now we will finish here at symptoms and the basics of the investigation. We will, in the next session, we will discuss about ECG, echo, thallium scan, and cardiopulmonary exercise testing, inshallah. So just we will have few minutes for the other symptoms. What about edema, Hasib? Edema is a cardiovascular system.
Yes. In the cardiovascular system, if the patient is having, as we discussed, left side heart failure, then on chest X-ray we will having typical bat-wing appearance or prominent upper lobe veins, enlarged peripheral lymphatics, and alveolar edema. On ECG, ischemic changes, hypertrophic and conduction abnormalities could be there. On ECG stress testing, we could find.
No, just a second. What other edema you are looking at? One is pedal edema. Okay. One is sacral edema. One is edema under the eyes. Okay. Usually in cardiovascular patient, and pulmonary edema or hepatic edema is formed in the form of hepatojugular reflex you are looking at, and pulmonary edema you are finding some basal crepitations. Okay. Or if it is even further, you will be finding some radiological findings as seen over here. Okay. So you have to correlate cough. You have to correlate with cough with sputum, cough with some infective signs. It will be going towards the respiratory system. Cough with the frothy sputum, with the crepitations, pulmonary edema. Okay. Similarly, cyanosis. Cyanosis is also finding maybe there in heart failure as well as in So sorry,
Respiratory.
cyanotic heart disease or respiratory disease. Okay, so
Yes.
you have to interpret. Now, what else? Hypoxia. Hypoxia may be either any type of hypoxia will be there. There are a number of in detail, but hypoxia may be
Syncope.
syncope. Syncope is a symptom, cardiac symptom, very important symptom. Thanks
Yes.
for
Cardiac
telling us.
symptoms.
Okay, palpitation. If you are if you are saying that patient is aware of the heart rate, it may be simple anxiety, or it may be a sign of hyperthyroidism, or it is any arrhythmia. Okay, so chest pain, dyspnea, palpitation, syncope. What else? Syncope may have a lot of differential diagnosis: neurological problem, cardiovascular problem, respiratory problem, electrolyte imbalance, endocrine, hormonal, like it may be anything. Okay, so syncope has so many
Sir,
reasons, but you yes.
sir, what will be the implication of anesthesia in patient undergoing treatment for pulmonary tuberculosis?
I'm sorry, your voice is distorted.
So my question: what will be the implications for anesthesia in a patient who is undergoing the treatment for pulmonary tuberculosis?
Albert, I will
This
answer
is
you
not
separately
on
because
today's
this is
topic.
not related to today's topic. I will answer you. Okay, you can just drop a message on WhatsApp. I will answer you. Because now we are short of time. Just go up, please. No, not down. Up. Just towards the sign symptoms. I just want to see if we can elaborate a little bit of them. So next time, whenever you are evaluating a patient, I would like you to interpret rather than only writing on, oh, more up symptoms more up. Asif. Yes, stay here in this slide. If we are missing any symptoms, we can elaborate a little bit and then we will finish. I think a little down, just a second. I can open it. We have seen cough. Yes, if it is blood tinge like hemoptysis may be there. It's a sign of pulmonary congestion. Okay, it may be there in cardiac problem. It may be there in respiratory problem. Okay, so and which is called as intermittent claudication. Intermittent claudication is like fatigue on movement, and then patient rest, and then fatigue goes on. So it is also a sign of peripheral vascular disease.
Yeah.
Okay, and what else? What else? Yes, dependent edema, signs of, and so now that's what our purpose was. Unfortunately, we started a little late, so I think you people get some advantage. Thanks a lot, all of you, to join us, and we will continue our discussion in next session,
Thanks to you.
inshallah.
Thank you so much for sharing your knowledge.
Yes. Okay.
Thank you, sir.
Thank you all the
Thank
participants.
you so much, Dr. Dishan. It was a wonderful session, although
Thank you, sir.
played by Dr. Hasif, but you have concluded well. I was unable to participate actually. Actually, I was in a conference in Karachi, and
Amir bhai, we will catch you for cardiac monitoring because that thing I lack a lot. So you have to be ready for cardiac output monitoring. Cardiopulmonary exercise testing, I have never seen it. Is it occurring in MIC?
yes, a few
Okay,
segment of exercise
because
are there, and
because I
definitely
don't.
in next session I will be free and will participate actively and will discuss these segment as well.
Okay, okay. Thanks a lot, everybody. We will finish here.
Thank you.